Welcome. This is my third version of going over the DSM-5 to help me study for the social work clinical exam. I have made some changes to some errors that I found in previous versions, as well as have added some more content to my notes. So the DSM-5 Diagnostic and Statistical Manual of Mental Disorders, 5th edition, was published in 2013 by the American Psychiatric Association. It's used for medical insurance, reimbursement for services, understanding conditions, and direction for treatment and intervention. The differences between the DSM-4 and the DSM-5 are that the DSM-4 was organized by age of onset versus the DSM-5 is organized by similarity of symptoms. The DSM-4 was a theoretical, theory neutral, whereas the DSM-5 is based on a medical reductionism model of neuroscience. The DSM-4 had axes 1 through 5, which also included the global assessment of functioning. The DSM-5 has no axes. It combined axis 1 through 3 with all mental and other medical diagnoses. The organization of the DSM-5 is based on category, which I have highlighted in my notes in apricot, a specific disorder under the category, which is a subcategory, which I have highlighted in lavender only for the subcategories that have subcategories. Other organization of DSM-5 are substance and medication-induced conditions and conditions due to another medical condition or disorders due to another medical condition. Not otherwise specified, NOS was replaced by other specified disorder and unspecified disorder. Other specified disorder allows the clinician to specify the reason that the criteria for the disorder are not met. Unspecified disorder allows the social worker or the clinician the option to forego specification. Other things that the DSM-5 assists with are codes for insurance reimbursement, ICD-10 codes. The ICD-11 are on their way, expected in January of 2022. Diagnostic criteria, prevalence, and differential diagnoses. What was deleted and is no longer found and not found in the DSM-5 are disorders usually first diagnosed in infancy, childhood, or adolescence is now listed under different chapters. The World Health Organization's disability assessment schedule was added to section 3, emerging measures and models under assessment measures. So the first category that you see in apricot is neurodevelopmental disorders, which is a new chapter. As you can see here, I have highlighted the subcategory of intellectual disabilities in lavender because there are subcategories. In other disorder categories that are highlighted in apricot will not have subcategories that are highlighted in lavender because there are no subcategories. So if you are looking at my notes as a visual aid, this will help you differentiate why I have color coded it. The main thing is that the main categories are in apricot. I have also indented the subcategories. So the subcategories under the category of neurodevelopmental disorders are intellectual disabilities, communication disorders, autism spectrum disorder, attention deficit hyperactivity disorder, specific learning disorder, motor disorders, tic disorders, and other neurodevelopmental disorders. Under the subcategory of intellectual disabilities, the subcategories are intellectual disability, also referred to as intellectual developmental disorder, global developmental delay, and unspecified intellectual disability, which is also in parentheses intellectual developmental disorder. So the subcategory intellectual disability, in parentheses intellectual developmental disorder, was previously called mental retardation. To specify severity, mild is 70 to 55, moderate is 55 to 40, severe is 40 to 25, and profound is 25 to 0. A deficit in intellectual functioning, learning, abstract thinking, judgment, reasoning, problem solving, planning, etc. Failure to meet developmental standards for independence and social responsibility. IQ scores and adaptive functioning are both used in determining client's ability, develops before 18 years old, and not due to another medical condition such as stroke or substance use. That is a description for intellectual disability, also called intellectual developmental disorder. The next subcategory is global developmental delay. Systematic assessment is not possible, nor assessment of severity. Under the age of 5 years old, does not reach expected milestones. The name again is global developmental delay. On to the next subcategory is unspecified intellectual disability, in parentheses, intellectual developmental disorder, diagnosed under 5 years old. Severity of intellectual disability is difficult or impossible to determine. That was unspecified intellectual disability, in parentheses, intellectual developmental disorder. All of those fell under intellectual disabilities, which fall under the category of neurodevelopmental disorders. The next subcategory under neurodevelopmental disorders is communication disorders. We would also need to refer the child to a psychologist. Under the subcategories under communication disorders are language disorder, speech sound disorder, childhood onset fluency disorder, also known as stuttering, social pragmatic communication disorder, and unspecified communication disorder. The first subcategory, language disorder, is spoken or written. Speech sound disorder, previously phonological disorder, is not due to physical or neurological or medical conditions. Child onset fluency disorder, stuttering. Social pragmatic communication disorder is new, has impaired social, verbal, nonverbal communication, and would need to rule out autism spectrum. Unspecified communication disorder is when other criteria for another not met. And remember that Other specified disorder allows the clinician to specify the reason that the criteria for the disorder are not met. An unspecified disorder allow the social worker the option to forego specification. Moving on to the next subcategory under neurodevelopmental disorders is autism spectrum disorder. The DSM5 incorporated Asperger disorder, childhood disintegrative disorder, and pervasive developmental disorder not otherwise specified. The DSM-4 pervasive developmental disorder included a few mental disorders which affect the development of communication and social skills in children, typically noticed by parents before a child is 3 years old. Main disorders: autism, Asperger syndrome, Rett syndrome, child disintegrative disorder. Miller's syndrome, a rare condition characterized by late onset, 2 to 12 years old, or severe or sudden reversal of developmental delays in language, motor skills, hallucinations, was previously under childhood disintegrative disorder, and that was Miller's syndrome. Rett syndrome was previously under pervasive developmental disorder, no communication, small hands and feet, repetitive movements, seizures, gastrointestinal issues, a rare genetic neurological and developmental disorder that occurs almost exclusively in girls that affects the way the brain develops, causing progressive loss of motor skills and speech. That was Rett syndrome. DSM-4 symptoms were divided into 3 areas: social reciprocity, communicative intent, and 3 restrictive repetitive behaviors. In DSM-5, the diagnostic criteria have been rearranged into 2 areas: social communication / interaction deficits. And the second area is restricted repetitive behaviors. So I'm going to go back a little bit. Autism spectrum disorder, you list the current severity with or without intellectual impairment, language impairment associated with a known medical, genetic, or environmental factor. 3, associated with another neurodevelopmental, mental, or behavioral disorder. Or 4, with catatonia. And if it's with catatonia, refer to a psychiatrist. So going back to the areas, the diagnostic criteria areas. In the DSM-5, the criteria must have all 3 from the social communication interaction deficits and have at least 2 from the restricted repetitive behaviors. So the social communication and interaction deficits are: 1, social emotional reciprocity, how a child responds, impaired conversation, lack of social initiation, no interest in people. Number 2, under the same area, nonverbal communication or poor use of. And 3, developing and maintaining friendships. Is there an impaired ability? And so there must have all 3 from this area as the diagnostic criteria. Under the second area, which is restricted repetitive behaviors, just need 2, one of which is stereotyped or repetitive movement, which also includes echolalia, which means repeated words, inflexible adherence to routine or fixated interests, or hypersensitive to sensory input. Moving on to the next subcategory under neurodevelopmental disorders, which is a new chapter, is attention deficit hyperactivity disorder. Inattentive or hyperactive symptoms must appear by age 12, occur in 2 or more contexts for at least 6 months. I'll repeat that. Attention deficit hyperactivity disorder, inattentive and or hyperactive symptoms must appear by age 12, occur in 2 or more contexts for at least 6 months. Subcategories are other specified and attention deficit hyperactivity disorder and unspecified attention deficit hyperactivity disorder. The next subcategory under neurodevelopmental disorders is specific learning disorder, which includes reading, dyslexia, writing, dysgraphia, math, dyscalculia, for at least 6 months. The next subcategory is motor disorders, which is a new subcategory. These subcategories under motor disorders are developmental coordination disorder and stereotypic movement disorder, which is repetitive, driven, purposeless, such as hand shaking, body rocking, head banging, not due to the direct effects of a substance, general medical condition, or mental disorder. The next subcategory under neurodevelopmental disorders are tic disorders, quick, non-rhythmic movements or vocalizations that occur over and over, not caused by other disorders such as Huntington's disease, substance abuse. There are simple and complex. Simple is short in duration, such as blinking, which is motor, throat clearing, which is vocal. Complex is longer in duration, often a combination of simple tics, for example, shaking head and shrugging shoulders. These subcategories under tic disorders are Tourette's disorder, must start before the age of 18 years old. There must be at least more than 2 motor and 1 vocal, and must persist for at least 1 year. So the criteria for Tourette's disorder, which is a subcategory of tic disorder, must start before the age of 18. There must be at least 2 motor and 1 vocal and persist for at least 1 year is the diagnostic criteria. The next subcategory under tic disorders is persistent chronic motor or vocal tic disorder. The diagnostic criteria is at least 1 motor or 1 vocal, but not both, for at least 1 year, and it started before 18 years old. So again, persistent chronic motor or vocal tic disorder has to have at least symptoms of 1 motor or at least 1 vocal, but not both, for at least 1 year and start before 18 years old, whereas Tourette's disorder is at least 2 motor and 1 vocal. So it has to have both. Whereas persistent motor or vocal tic order, it's either or. The next subcategory is provisional tic disorder. Starts also before the age of 18 years old. There has to be at least 1 motor and or 1 vocal and persist for less than a year. So for provisional tic disorder, the symptoms required are 1 motor and or 1 vocal and persist for less than a year. The next subcategory under tic disorders is unspecified tic disorder. The next subcategory under neurodevelopmental disorders is other neurodevelopmental disorders. This also includes other specified neurodevelopmental disorders and unspecified neurodevelopmental disorders. And remember that other specified disorder means the clinician specifies the reason that the criteria for the disorder are not met. An unspecified disorder allows the clinician the option to forego specification. The next main category is schizophrenia spectrum and other psychotic disorders and other conditions associated with psychotic symptoms. Psychotic symptoms do not necessarily indicate schizophrenia. There are other conditions associated with it. So before we jump into the different subcategories, I'm going to go over some definitions, which are important. So there are symptoms that are called positive symptoms and negative symptoms. The positive symptoms are delusions, hallucinations, disorganized speech, which is also referred to as disorganized thinking, grossly disorganized or catatonic behavior. These are all positive symptoms. Negative symptoms are how I differentiate is like positive is you're adding something and negative is something is reduced or taken away. So under negative symptoms, the person's going to have, for example, low energy, everything is slowed, they're apathetic, poor hygiene, flat affect, anhedonia, lack of pleasure, they're asocial, they're solitary, they withdraw from friends and family, evolution, the lack of motivation, alogia, diminished speech, inability or difficulty to speak, poor eye contact, cognitive deficits, impaired thinking, they can't keep a job. These are all negative symptoms. I would leave that can't keep a job out of the negative symptom, but let's see here. Then there are psychotic and psychosis. So I'm going to go into the definition of delusions. Fixed and false beliefs that are not based in reality and that the person refuses to give up, even when presented with factual information. A false belief based on incorrect inference about external reality that is firmly sustained despite what almost everybody else believes and despite what constitutes incontrovertible and obvious proof of evidence to the contrary. believing in something that is not true. And you need to make sure too that it's about the cultural context. So if this person is from another culture, to make sure that the people in their culture agree that it's not true. So you want to make sure that it's culturally based or not based. So there are two types of delusions, non-bizarre and bizarre. Non-bizarre is delusion that is possible but unlikely. So for example, the government is spying on this person. It's possible, but not probable. Bizarre is implausible. It's not possible. It's not derived from ordinary experiences. Like, for example, they think they are an alien. There are no prominent hallucinations, thought disorder, mood disorder, or significant flattening of effect. So these things cannot be present with the delusion. No prominent hallucination, thought disorder, mood disorder, or significant flattening of effect. Hallucinations are a wakeful sensory experience affecting the five senses that is actually not present. So haptic touch, gustatory taste, auditory, which is the most common, visual, olfactory, which is smell. So they're perceiving something through their senses. They think they're perceiving something, but they're not because it's not actually there. Disorganized speech, which is also referred to as disorganized thinking, thoughts easily derailed and does not come back to the original point, topic, or thought. They're very tangential. There's disorganized speech, word salad, thought blocking. Under the positive symptom of grossly disorganized or catatonic behavior, gets in the way of normal functioning, outbursts of laughter or anger, repetitive, senseless movements, walking in circles, writing constantly, repeated movements with no rhyme or reason, pacing, adopting a pose which may be maintained for hours. Individual resists efforts to be moved into a different position or will assume a new position for hours. Psychotic is experiencing delusions or hallucinations, cannot differentiate between what is real and what is not real, can be caused by substances. Psychosis, there's 4 clinical manifestations. 1, delusions, 2, hallucinations, 3, thought disorders, 4, agitation, aggression. Illnesses with psychosis, or some illnesses with psychosis include brief psychotic disorder, schizophreniform, schizophrenia, schizoaffective, schizotypal, major depressive disorder, bipolar disorder, and substance-induced. Secondary psychosis can be caused by thyroid, adrenal, hepatic diseases, Alzheimer's, Huntington's, and strokes. Schizophrenia is categorized as a thought disorder resulting from abnormal activity in 2 neurotransmitters, serotonin and dopamine. Symptoms typically include hallucinations, bizarre delusions, emotional unresponsiveness, and social withdrawal and agitation. So I think I just wanted to make clear, think back in delusions, I didn't make it clear that I did define non-bizarre and bizarre. So when somebody is having under delusional order, they would only have non-bizarre. They would not have bizarre delusions for delusional disorder. Okay, so delusional disorder, which is a subcategory under schizophrenia spectrum and other psychotic disorders, delusions can be odd but non-bizarre. And remember, non-bizarre is the delusion is possible but not probable. So somebody could say something that it could almost seem like it could be true, but it's just so probably it's not, like government spying or something like that. So back to delusions can be part of other disorders, for example, mania, substance. It's a prodrome to schizophrenia. There are subtypes of delusional disorder. And in my notes, it says can only be one and must have for 1 month. So erotomanic is like the stalker, grandiose, jealous, persecutory, somatic, and differential diagnosis is substance use. Mixed type, when there's more than one subtype. Unspecified, when there's no clear subtype. For example, thought broadcasting and people are reading their minds. Differential diagnosis is brief psychotic disorder if time requirement is not met. However, multiple specifiers can be indicated. No longer separate from shared delusional disorder, otherwise known as folie à deux. So the new criteria for delusional disorder is A through E, non-bizarre, which is non-psychotic. A is presence of one or more delusions for at least 1 month. Criterion B is criterion for schizophrenia has never been met. Criterion C, no impaired functioning except from the delusion. And criterion D, if manic or mood symptoms are present, they must be mild or short in duration. Differential diagnosis, not better explained by another medical condition. So delusional disorder, the new criteria A through E, non-bizarre, must be present for at least 1 month and must have one or more delusions. There are subtypes. And that is criterion A, but the criteria is A through E. So you have that time period. They've never been diagnosed for schizophrenia. There's no impaired functioning. If manic or mood symptoms present, they must be mild or short in duration. And differential diagnosis not better explained by another medical condition. So that's A through E. So I had skipped over schizotypal, which is personality disorder, which I'm going to discuss in the personality section. That was schizotypal. That is under the category of schizophrenia spectrum and other psychotic disorders. So moving on from delusional disorder to brief psychotic disorder, there must be at least one of the following symptoms: delusion, hallucinations, disorganized speech, or grossly disorganized or catatonic behavior. The symptoms last at least 1 day, but less than 1 month. There is a return to premorbid functioning caused by a major stressor and can be caused by a major stressor. So brief psychotic disorder, at least one of the following symptoms, which are positive symptoms: delusion, hallucination, disorganized speech, or grossly disorganized or catatonic behavior. Symptoms last at least 1 day, but less than 1 month. So remember, the delusional disorder, you have to have at least one or more of the delusions for at least 1 month. But brief psychotic disorder, you have to have a positive symptom for at least 1 day, but less than 1 month. And this can be caused by stress as well. Schizophreniform disorder has to have at least 2 of these positive symptoms: delusions, hallucinations, disorganized speech, or grossly disorganized or catatonic behavior. And the symptoms have to be there greater than a month, but less than 6 months. And negative symptoms can be present. The mood is mood neutral delusions, usually bizarre. So the brief psychotic disorder and schizophreniform disorder, usually the delusions are bizarre, where in delusional disorder, it will be non-bizarre. And remember, non-bizarre is possible, but not probable, and bizarre is it's not possible. Schizophrenia are 2 or more of the positive symptoms, which is delusions, hallucinations, disorganized speech, plus grossly disorganized or catatonic. May have negative symptoms. These are not episodic, rather it's constant. It can be up and down, but it's not episodic like bipolar. The psychotic symptoms must be present for at least 6 months and at least 1 month of active symptoms. Onset is around 25 years old. These are mood neutral delusions and usually bizarre. So moving on to schizoaffective disorder, meets criteria for schizophrenia, plus criteria for mood disorder, like depression or bipolar. For majority of illness and have psychosis for more than 2 weeks in absence of mood disorder. Primary disorder is delusions and hallucinations. So there must be a psychosis in absence of the mood disorder. So schizoaffective disorder has to meet the schizophrenia criteria plus a major mood episode like depression or bipolar with delusions and or hallucinations present for at least 2 weeks without the mood disorder present. Differential diagnosis: mood disorder with psychotic features if mood is more prominent than psychosis. Constant mood disorder with intermittent psychosis. That's the DDX, mood disorder with psychotic features if mood is more prominent with psychosis. The next subcategory is substance medication-induced psychotic disorder, psychotic disorder due to another medical condition, and catatonia, which also has subcategories. So catatonia, behavior, motor function, there are 3 types. Catatonia is a specifier for depressive, bipolar, and psychotic disorder. So catatonia is a specifier for depressive, bipolar, and psychotic disorder. Another mental disorder, another medical condition may due to any number of disorders. Requires 3 of the 12 symptoms for diagnosis. These symptoms include stupor, mutism, posturing, grimacing, echolalia, waxing flexibility, negativism, mannerisms, agitation, stereotyping, echopraxia is the copying of others' movements. The subcategories are catatonia associated with another mental disorder, which is a catatonia specifier, catatonic disorder due to another medical condition, which is a catatonia specifier, unspecified catatonia, other specified schizophrenia spectrum and other psychotic disorder, unspecified schizophrenia spectrum and other psychotic disorder. Moving on to the next category is bipolar and related disorders. Can have psychosis, hallucinations when manic or depressed. The primary criteria for manic and hypomanic episodes, criterion A, now includes an emphasis on changes of activity and energy, not just mood. New specifier with mixed features can be applied to bipolar 1, 2, or not elsewhere defined, previously called not otherwise specified, can be applied to episodes of mania or hypomania when depressive features are present, and that specifier is called with mixed features. Specifier anxious distress, anxiety symptoms added to bipolar disorder and to depressive disorders, but are not part of the bipolar diagnostic criteria. That specifier is called anxious distress. Depressive episodes and symptoms include sadness, loss of interest in usual activities, sleep appetite disturbances, feelings of worthlessness and guilt, difficulties thinking or concentrating, suicidal thoughts or reoccurring thoughts of death. The subcategories under bipolar and related disorders include bipolar 1 disorder, bipolar 2 disorder, cyclothymic disorder, substance medication-induced bipolar and related disorder, bipolar and related disorder due to another medical condition, other specified bipolar and related disorder, unspecified bipolar and related disorder. The differential diagnosis is schizoaffective, psychosis even when mood is stable. To dive in deeper to bipolar 1 disorder, we have mania, psychotic features. Delusions will usually match their mood. Distractible, irresponsible, irritable, impulsive, grandiosity, flight of ideas, activity increased, sleep decreased, insomnia, talkative, racing thoughts, rapid speech, increase in goal-oriented activities, excessive involvement in activities, risky behavior, euphoria, disregard for the consequences of behavior, psychomotor agitation, expansive. The symptoms to diagnose bipolar 1, symptoms of mania lasting greater than or at least 1 week or any duration of hospitalization, may have hypomanic 4 days or longer, or a major depressive episode. 3 or more of the 7 symptoms are present, and I had just listed that under the mania section. There may be rapid shifts of elevated mood to anger or depression. So bipolar 1, the symptoms of mania must last at least 1 week or any duration of hospitalization, may have hypomanic 4 days or longer, or a major depressive episode. 3 or more of the 7 symptoms are present. The main difference between bipolar 1 and bipolar 2 is bipolar 1 has mania and does not require an episode of depression. Bipolar 2 disorder requires a present or past episode of major depression episode and hypomanic. Hypomania is similar to mania, but disturbances are not as severe enough to cause marked social occupational functioning or hospitalization. A distinct period of abnormally and persistently elevated, expansive, or irritable mood, abnormal, persistent, increased activity or energy. So the diagnostic criteria for bipolar 2 disorder requires a present or past episode of major depression episode and hypomania. Symptoms of hypomanic lasting at least 4 days, present most of the day, nearly every day, and depression for at least 2 weeks. 3 or more of the 7 symptoms are present, does not have a clinically significant impact on their functioning. I'll repeat that again. Bipolar 2 disorder, the symptoms do not have a clinically significant impact on their functioning. In cyclothemic disorder is subclinical mania and depression for 2 years, at least half of the time, and constant for 2 months. So cyclothemic disorder is subclinical mania and depression for 2 years, at least half the time, and constant for 2 months. Other specified bipolar and related disorder for clients with a history of major depressive disorder who meet all criteria for hypomania except the duration criteria, for example, at least 4 consecutive days, or too few symptoms of hypomania are present to meet the criteria for bipolar 2, although the duration is sufficient, at least 4 or more days. Moving on to the next main category called depressive disorders. What was removed was the bereavement exclusion. There are new specifiers. A new specifier is available for those clients who display suicidality factors and are depressed. So the new specifier is available for clients who display suicidality factors and are depressed. A new specifier allows for the presence of mixed symptoms across both bipolar and depressive disorders, allowing for the possibility of manic features in clients with a diagnosis of depression. The specifier with anxious distress also gives clinician the opportunity to rate the severity of anxious distress in all clients with bipolar or depressive disorders. Instruments include Beck's Depression Inventory, Geriatric Depression Inventory, Children's Depression Inventory, Beck Hopelessness Scale, and the Patient Health Questionnaire, PHQ-9. The subcategories under depressive disorders include disruptive mood dysregulation disorder, which is new, major depressive disorder, single and recurrent episodes, persistent depressive disorder, premenstrual dysphoric disorder, which is new, substance medication-induced depressive disorder, depressive disorder due to another medical condition, other specified depressive disorder, and unspecified depressive disorder. Differential diagnosis would be major depressive versus persistent depressive disorder. And I'll go into more detail about that. There's a break versus no break in depression. So diving into disruptive mood dysregulation disorder, these are temper outbursts that are, one, out of proportion to situation in intensity or duration, and two, inconsistent with developmental level. Age of onset is before 10 years old. Diagnostic age is between 6 and 18 years old. Created in response to the overdiagnosis and overprescription of childhood bipolar disorders and medications. That subcategory is called disruptive mood dysregulation disorder. Major depressive disorder, single and recurrent episodes. Observations from others are included, such as observing someone who is tearful, down, and isolating from others. Must have 5 of the 9 symptoms, such as loss or gain weight, lack of energy, sluggish fatigue, feelings of guilt or worthlessness, cognition and concentrating troubles, appetite disturbances, sleep disturbances, which includes insomnia or hypersomnia, psychomotor agitation, retardation, suicidal ideation, and thoughts of death for at least 2 weeks. So major depressive disorder, single and recurrent episodes, at least one must be present of the gatekeeper criteria. The gatekeeper criteria includes depressed mood and or loss of interest and pleasure. I should highlight that. So these are the gatekeepers. There must be at least one of these fulfilled. In addition, so the gatekeeper, the person has to have at least a depressed mood and or loss of interest in their pleasure. They still have to have 5 of the 9 symptoms for more than 2 weeks. Symptoms represent a change from previous functioning, may have episodes that last 2 or more years, but there is a break from depression in between. In persistent depressive disorder, there is no break. The symptoms last at least 2 years with less than 2 months between episodes. They're sad, chronic, milder mood disturbances. Persistent depressive disorder was previously dysthymia, and chronic major depressive disorder. It's a low-grade, long-lasting depression, low mood almost every day. They have no break. So that's where the differential diagnosis comes in between major depressive and persistent depressive disorder. So the symptoms are milder, but they're low mood almost every day for at least 2 years with less than 2 months between episodes. Premenstrual dysphoric disorder is new. At least one symptom from criterion A and 5 or more symptoms from both criterion A and B. In most menstrual cycles during the past year must occur during the final week before the onset of menses, start to improve within a few days after the onset of menses, and be minimal or absent in the week post menses. So at least one symptom from criterion A. So they either have to have affective lability, irritability or anger, or depressed mood or anxiety. So they have to have one of those symptoms to fulfill criterion A. And they have to have 5 or more symptoms from both criterion A and B. And criterion B is decreased interest in activities, poor concentration, lethargy, appetite changes, hypersomnia or insomnia, feelings of being overwhelmed, physical symptoms like breast soreness and bloating. So it occurs in most menstrual cycles during the past year, must occur during the final week before the onset of menses, and start to improve within a few days after the onset of menses, and be minimal or absent in the week post menses. Moving on to the next major category, which is anxiety disorder. Let's see. So some of the instruments include Beck's Anxiety Inventory, Hamilton Anxiety Rating Scale, the Generalized Anxiety Disorder Questionnaire, GAD-4 and GAD-7, Trait Anxiety Subscale of the State Trait Anxiety Inventory, Overall Anxiety Severity and Impairment Scale, Patient Health Questionnaire, PHQ-4, and Penn State Worry Questionnaire. The subcategories found under anxiety disorder include separation anxiety disorder, selective mutism, specific phobia, social anxiety disorder, also called social phobia, panic disorder, agoraphobia, generalized anxiety disorder, substance medication induced anxiety disorder due to another medical condition, other specified anxiety disorder, unspecified anxiety disorder. So separation anxiety disorder, previously disorder of early onset, is the fear of a loved one not coming back. This is diagnosed in both children and adults, usually children 0 to 7 years old, and symptoms must last at least 4 weeks in children, whereas in adults, symptoms must last for at least 6 months. Selective mutism was also previously a disorder of early onset, occurs in specific social situations, not all the time, and symptoms must last more than 1 month. Specific phobia, there are 4 types: animal, natural environment, blood injection injury, and situational, like on a plane or an elevator. Fear may have developed from related trauma. Symptoms must last at least 6 months, and fear is out of proportion to the situation or object, or threat removal reduces anxiety immediately. So fear is out of proportion to the situation or object or threat, and removal reduces anxiety immediately. That's specific phobia. Social anxiety disorder, also called social phobia, is fear of one or more social situations lasting greater than 6 months. And they suffer significant distress or impairment. The DSM5 shifted criteria in that the clinician judges if response is excessive or unreasonable rather than the client, as in the DSM4. So fear of one or more social situations for more than 6 months. Panic disorder has been separated from agoraphobia. And I'm going to define panic attack first. And panic attack is not a disorder. It's a specifier only. And it fulfills criterion A in panic disorder. It can be sudden periods of intense fear, like pounding heart, palpitations, sweating, trembling, shortness of breath, chest pain, feelings of choking, dizzy, faint, chills or heat, tingling, paresthesia, derealization or depersonalization, fear of dying, fear of losing control, being crazy. There can be a fear about reoccurrence, and differential diagnosis is afibrillation, substances, and hyperthyroidism. So panic attacks, sudden periods of intense fear, and then they have all these physiological reactions. They're not going to have all of these. They could just have some people experience different physiological symptoms. So someone could have a pounding heart and palpitations. They could sweat, but they wouldn't have, say, for example, they weren't dizzy or didn't have chills or didn't have tingling feeling. So in order to have panic disorder, you have to have at least 4 symptoms of criterion A, the panic attack, plus at least 1 symptom for 1 month following the panic attack, criterion B. So at least 4 symptoms of criterion A, the panic attack, plus at least 1 symptom for 1 month following the panic attack. So it's like when you continue to have panic attacks, you get panic disorder. Agoraphobia is afraid of unsafe environment, unable to escape. Fear and avoidance of at least 2 of the 5 situations: public transit, open spaces, enclosed spaces, lines and crowds, leaving the house. And symptoms persist for more than 6 months. So symptoms persist more than 6 months. And to go back to the panic attack, some people, all they will ever have is 1 panic attack in their whole life, whereas some people have panic attacks several times a year, and that would be panic disorder. So, and remember, and then I'm going back to agoraphobia, afraid of unsafe environment, unable to escape. So they're afraid of public transportation, open spaces, enclosed space, or lines and crowds, or leaving the house. So they have to have they fear and avoid at least 2 of the 5 situations that I just listed for more than 6 months. Generalized anxiety disorder, you have to have 3 or more of the symptoms for more than 6 months and must interfere with daily functioning. So restlessness, fatigue, difficulty concentrating, irritable, muscle tension, sleep disturbance, worry about multiple things. So they have to have 3 or more symptoms for more than 6 months and must interfere with daily functioning. Moving right along to the next category, which is obsessive compulsive related disorders. Under this category are several subcategories, which include obsessive compulsive disorder, body dysmorphic disorder, which is a new criteria, has new criteria, hoarding disorder, which is new, trichotillomania, hair pulling disorder, excoriation disorder, which is compulsive skin picking, which is new, substance medication induced obsessive compulsive and related disorder, new, obsessive compulsive and related disorder due to another medical condition, new, other specified obsessive compulsive and related disorder, and unspecified obsessive compulsive and related disorder. So diving into the subcategory of obsessive compulsive disorder, which is under the category of obsessive compulsive and related disorders, obsessive compulsive disorder, obsessions are frequent, reoccurring upsetting thoughts or urges that cannot be ignored. Compulsions are the behavior used to assuage the obsessions, like repetitive rituals as a means of reducing anxiety or preventing an event. Feels compelled to perform them. For example, germs are the obsession, cleaning is the compulsion. Feelings of unsafe are the obsession, checking is the compulsion. Something bad will happen is the obsession. Repeating is the compulsion. Something causing anxiety is the obsession. Arranging is the compulsion. So for criterion 1, obsessions, compulsions, or both, time consuming. Criterion 2 is time consuming, distress to daily life, at least 1 hour a day, and affects relationships. Criterion 3, not physiologic effects of substance or medical condition. Criterion 4, not better explained by another disorder, for example, dysmorphic disorder. So that's the diagnostic criteria. Obsessions. So the first criteria has to be obsession, compulsion, or both. Criterion 2 is it's time consuming and distressful to daily life. It has to occur for at least 1 hour a day and affect the relationships. Criterion 3, not physiologic effects of substance or medical condition. And criterion 4, not better explained by another disorder. So moving on to body dysmorphic disorder, which is new. Preoccupation with perceived defects in appearance which are not observable or appear minor to others. Repetitive behaviors like mirror checking and grooming, or mental acts like comparing themselves that may arise with perceived defects or flaws. Specifiers expanded. Good or fair insight, poor insight, and absent insight / delusional. For example, complete conviction that obsessive compulsive disorder beliefs are untrue. And these specifiers also are the same ones used for hoarding disorder. So hoarding disorder, persistent difficulty and distress parting with possessions due to a perceived need to save items regardless of actual value, results in accumulation with clutters to the point of compromising intended use. So the specifiers are good or fair insight, poor insight, and absent insight / delusional. Then we're moving on to trichotillomania, hair pulling. This was moved from impulse control disorders, not elsewhere classified. Under other specified obsessive compulsive and related disorder includes body focus repetitive behavior disorder, behaviors like nail biting, lip biting, and cheek biting, other than hair pulling and skin pricking, because they have their own subcategory disorder that I just went over, or obsessional jealousy. So other specified obsessive compulsive and related disorder includes nail biting, lip biting, and cheek biting, obsessional jealousy, body dysmorphic like disorder with actual flaws, and body dysmorphic like disorder without repetitive behaviors, and then cultural variations. Moving on to the next main category is trauma and stressor related disorders. Any situation that leaves a client feeling overwhelmed. Associated with trauma are 1, unexpected, 2, not prepared, 3, powerless, 5, repeated. I think I numbered off correctly. 4, repeated, 5, cruelty, and 6, childhood. So unexpected, not prepared, powerless, repeated, cruelty, and occurred in childhood. The subcategories under trauma and stressor related disorders include reactive attachment disorder, disinhibited social engagement disorder, post-traumatic stress disorder, acute stress disorder, adjustment disorder, other specified trauma and stressor related disorder, unspecified trauma and stressor related disorder. Diving into the first subcategory, reactive attachment disorder. Previous a subtype, now a separate disorder, occurs from the failure to thrive, inhibited, withdrawn social emotional disturbance. Diagnosed in children before the age of 5 years old. So onset is before 5. History of insufficient care, neglect, gross neglect is reactive attachment disorder. Disinhibited social engagement disorder, previously a subtype, now a new separate disorder. These children are overly familiar and friendly with strangers and prone to wander off. There is a history of insufficient care and neglect. Symptoms persist at least 12 months. And that was disinhibited social engagement disorder. So both reactive attachment disorder and disinhibited social engagement disorder occur in children and are due to insufficient care and are from neglect. Post-traumatic stress disorder. Criteria has been modified and now has 4 clusters. So there's criterion A. I'm just going to list through the criteria first. Criteria A is the stressor. Direct exposure, witnessing trauma, learning from close friend or relative who was exposed, indirect exposure, or exposed to details like first responders and military. Criterion B is the intrusion. Unwanted intrusive memories, flashbacks, nightmares, emotional distress, physical reactivity. Criterion C is the avoidance of trauma-related stimuli, thoughts, feelings, external reminders. Criterion D are the negative mood cognition, inability to recall key details of trauma, overly negative thoughts of self or world, excessive blame of self and others, negative affect, decreased interest in activities, and feeling isolated. Criterion E, altered arousal affect, irritable, aggressive, hypervigilant, risky or destructive behavior, heightened startled response, difficulty concentrating, and difficulty sleeping. So the criterion, there are different for adult and children. So in adults, one symptom of intrusion, it must be at least one symptom of intrusion and 2 symptoms of arousal, or 1 symptom of avoidance and 2 symptoms of the negative. So 1 symptom of intrusion, that's criterion B, unwanted intrusive memories, flashbacks, nightmares, emotional distress, physical reactivity, and 2 symptoms of arousal, criterion E, irritable, aggressive, hypervigilant, risky, or destructive behavior, heightened startled response, difficulty concentrating, difficulty sleeping. Or 1 symptom of avoidance, criterion C, and 2 symptoms of negative mood cognition. So the avoidance is avoidance of trauma-related stimuli, thoughts and feelings, and external reminders. Criterion D is the inability to recall key details of trauma, overly negative thoughts of self or world, excessive blame of self or others, negative affect, decreased interest in activities, and feeling isolated. So I'll say that again, symptoms for greater than 1 month and must have at least 1 symptom of intrusion and 2 symptoms of arousal, that's B and E, or 1 symptom of avoidance and 2 symptoms of negative, that's C and D. In children, the difference is just in the, they just have to have 1 symptom of the negative. So 1 symptom of the avoidance and 1 symptom of the negative. That's the difference between the adult and the children. I should do this in a different color. Because that, okay. So acute stress disorder has similar symptoms and diagnostic criteria to PTSD, but with 3 days to 1 month. So it's a precursor to PTSD. So the criteria was modified symptoms for 3 days to 1 month. Symptoms are less than 1 month. And trauma occurred, has to occur within 1 month from the trauma. So acute stress disorder, 3 days to 1 month, occurs less than 1 month from the trauma. If it's more than 1 month, then it turns into PTSD, depending on what criteria it meets. But just for as far as the timetable. Adjustment disorder, moved, and now stress response syndrome. Distress that is out of proportion to the stressor, resulting in social or occupational impairment. Symptoms include loss of interest, crying, feeling of hopelessness, and remember, it excludes bereavement, aka situational depression. Stressor happened 3 months or less from onset of symptoms, and symptoms should end within 6 months after stressor ends. So symptoms cannot appear more than 6 months from life change. So stressor happened 3 months or less from onset of symptoms. Symptoms should end within 6 months after stressor ends. Symptoms cannot appear more than 6 months from life change. Moving on to dissociative disorders. So the subcategories under dissociative disorders include dissociative identity disorder, dissociative amnesia, depersonalization and derealization disorder, other specified dissociative disorder, unspecified dissociative disorder. The subcategory dissociative identity disorder criteria were expanded to include possession form phenomena and functional neurological symptoms. Again, criteria were expanded to include possession form phenomena and functional neurological symptoms. It is made clear that the transitions in identity may be observable by others or self-reported. Criterion also modified for those who experience gaps in recall of everyday events, not only trauma. Dissociative identity disorder is very rare. 2 or more distinct personality states, each of which perceives and relates individually to the world and the self. This is referred to as the split personality. Dissociative amnesia, the inability to recall autobiographical information, often related to stress, trauma, not explained by ordinary forgetfulness. Dissociative fugue, I never say it right, dissociative fugue, became a specifier, specify with fugue, wandering, if there's wandering, forget who they are and live as someone else is a specifier. If they forget who they are and live with someone else, that's dissociative amnesia. Dispersonalization, derealization disorder. Depersonalization is feelings of unreality, detachment related to thoughts, feelings, body, feeling surreal out of body. Derealization, feelings of unreality, detachment related to surroundings or objects. This was previously just depersonalization disorder, but now it's depersonalization / derealization disorder. Somatic, the next main category is somatic symptom and related disorders, previously somatoform disorders. What was deleted was hypochondriasis, pain disorder, undifferentiated somatoform disorder, and somatization disorder are now somatic symptom disorder. Medically unexplained symptoms are not needed except in the cases of conversion disorder or pseudopsoriasis, false pregnancy. Pseudopsoriasis. People with chronic pain can now be diagnosed with 1, somatic symptom disorder with predominant pain, or 2, psychological factors that affect other medical conditions, or 3, adjustment disorder. So people with chronic pain can now be diagnosed with one of those 3, somatic symptom disorder with predominant pain, or 2, psychological factors that affect other medical conditions, or 3, adjustment disorder. The subcategories under somatic symptom and related disorders, previously somatoform disorders, include somatic symptom disorder, illness anxiety disorder, conversion disorder, and in parentheses, I have functional neurological symptom disorder, psychological factors affecting other medical conditions, factitious disorder, other specified somatic symptom and related disorder, unspecified somatic symptom and related disorder. So jumping into somatic symptom disorder, distressing real symptoms with excessive thoughts, feelings, or behaviors that are 1, health-related anxiety, 2, disproportionate and persistent fear about seriousness of symptoms, and 3, excessive time and energy devoted to these symptoms or concerns. So the diagnostic criteria is 1 or more somatic symptoms accompanied by at least 2 of the following cognitive behavioral symptoms, which persist for at least 6 months. And I had listed those off. Distressing real symptoms with excessive thoughts, feelings, or behaviors. 1, health-related anxiety. 2, disproportionate and persistent fear about seriousness of symptoms. 3, excessive time and energy devoted to these symptoms or concerns. So the symptoms which persist for at least 6 months. Specify if with predominant pain, and specify severity. Negatively affects daily functioning. Illness anxiety disorder. Excessive fear or worry about health with no or minimal symptoms. So somatic symptom disorder has symptoms, real physical symptoms. Illness anxiety disorder has no or minimal symptoms. A person's believes this more than 6 months, at least 6 months, that he has or will have a serious disease, despite reassurance from a doctor that no disease is present. Conversion disorder, and in parentheses, functional neurological symptom disorder, psychological stress manifesting in body symptoms. The client does not produce or control them voluntarily. Diagnostic criteria: 1 or more neurologic, voluntary motor or sensory impairments that are not caused by a general medical condition, substance, or neurological disorder. So that's a conversion disorder. 1 or more neurologic, so it's voluntary motor or sensory impairments. So 1 or more neurological impairments that are not caused by a general medical condition, substance, or neurological disorder. It's psychological stress manifesting in a body symptom. Factitious disorder, previously Munchausen syndrome, and Munchausen syndrome by proxy, now factitious disorder imposed on another. Munchausen syndrome is the most extreme and dramatic and can include the seeking of multiple invasive procedures. So factitious disorder is falsifying physical or psychological symptoms without external incentive. They are in the sick role. Just think of sick role. They are not doing this for external incentives. So falsifying physical or psychological symptoms without external incentive, which needs to be distinguished from malingering, which is not a disorder. It's when someone intentionally fakes a disorder for external incentives like time off, money, medications. So the differential diagnosis is factitious disorder should be distinguished from malingering and somatic symptom and related disorders. So factitious disorder, there's no other incentive other than to experience the sick role. Both factitious disorder and malingering are false and deceptive, but there is no deception with somatic symptom disorder, illness, anxiety disorder, or conversion disorder. What's occasionally paired together, though, are the two deceptive roles, factitious disorder and malingering. And what is rarely paired is factitious disorder and the other somatic symptom and related disorders. Feeding and eating disorders. The subcategories under feeding and eating disorders include pica, rumination disorder, avoidant restrictive food intake disorder, anorexia nervosa, bulimia nervosa, binge eating disorder, which is new, other specified feeding or eating disorder, unspecified feeding or eating disorder. The differential diagnosis is between bulimia and anorexia. So the first subcategory under feeding and eating disorders is pica, which is eating non-nutritive things, food, not eating non-nutritive food or non-food. Now refers to clients of any age, and symptoms must last for at least 1 month. Rumination disorder is repeated regurgitation of food, now refers to clients of any age. Symptoms must last for at least 1 month. Avoidant restrictive food intake, previously feeding disorder of infancy or early childhood, not better explained by lack of food, culturally sanctioned practice or eating disorder, like body image motivation. Eating disturbance resulting in one of these 4 symptoms. 1, weight loss. 2, nutritional deficiency. 3, dependence on feeding tube or nutritional supplements. 4, interference with psychological functioning. That disorder is called avoidant restrictive food intake disorder. Anorexia nervosa is distorted self-perception, fear of weight gain, food restriction resulting in significantly low weight. Most deadly and dangerous diagnosis in the DSM5. No longer required is amenorrhea. That is anorexia nervosa. Bulimia nervosa is binge eating, then purging. They vomit or use laxatives and diuretics and that sort of thing. Symptoms last at least one time or occur one time per week over 3 months. And this is new criteria. So bulimia nervosa as symptoms are at least one time per week over 3 months. Binge eating disorder is new. Eating more than normal or appropriate, sense of lack of control over eating. Symptoms occur at least one time per week over 3 months. Marked distress correlated with greater personality disturbance, anxiety, and mood problems. So the difference between bulimia and anorexia, both can have binging and purging, bone loss, and teeth problems. But anorexia involves body dysmorphic problem where the client sees self as overweight when they are dangerously thin, usually 30% below average. If too thin, referred to a doctor or psychiatrist and may require inpatient. Next being category is elimination disorders can indicate abuse or caused by stress like divorce or separation anxiety. These subcategories under elimination disorders are enuresis, involuntary urination, must rule out medical reasons like infection or other abnormalities, encopresis, involuntary bowel movement, which is inappropriate bowel movements in places causing embarrassment. Other specified elimination disorder, unspecified elimination disorder. Moving on to the next main category is sleep-wake disorders. There are many subcategories and subcategories under sleep-wake disorders. And to save time, I'm not going to go through them first, I'm just going to dive right in. So deleted was sleep disorders related to another mental disorder and sleep disorders related to a general medical condition. Now, those were deleted. Sleep disorders related to another mental disorder, deleted. Sleep disorder related to a general medical condition, deleted. So the subcategory under sleep-wake disorders is insomnia disorder, previously primary insomnia, hypersomnolence disorder, when they sleep too much, narcolepsy, falling asleep randomly, breathing-related sleep disorders, and there's many subcategories like obstructive sleep apnea, hypopnea, central sleep apnea, sleep-related hypoventilation, circadian rhythm sleep-wake disorders, includes advanced sleep phase syndrome, irregular sleep-wake type, and non-24-hour sleep-wake type. Jet lag was deleted. The next main subcategory under sleep-wake disorders is parasomnias, a sleep disorder that causes abnormal behaviors or movements while sleeping. So there's a couple different types. There's non-rapid eye movement sleep arousal disorder, and under non-rapid eye movement sleep arousal disorders are sleepwalking and sleep terrors and confusional arousal. So non-rapid eye movement sleep arousal disorder usually occurs in the first third of sleep, unresponsive to being woken up, but can be woken up. They usually do not remember, they have amnesia, and there's no dreaming during this time. So this is also a new separate disorder, this non-rapid eye movement sleep arousal. So for sleepwalking, there's two, it's a subtype of this non-rapid eye movement sleep arousal. There's two specifiers, sleep-related eating and sex-related behavior. There are other behaviors. may wake up confused and at risk for injury or danger. Sleep night terrors is a subtype. Crying usually may wake up confused, and confusional arousals wakes up in a very confused state. The next subcategory under parasomnia, or it's called a subcategory, is nightmare disorder. And then rapid eye movement sleep behavior disorder. They can wake up easily, different than sleepwalking and sleep terrors. This is during when they have vivid dreams and they act them out during REM sleep. Other parasomnias include sleep-related dissociative, sleep enuresis, bedwetting, sleep-related groaning, exploding head syndrome. This is when they're about to sleep or wake up and they imagine a loud noise. Teeth grinding, sleep-related hallucinations. They see, feel, or hear hallucinations when they're about to sleep or wake up. Sleep-related eating disorder, substance medication-induced parasomnia, and unspecified parasomnia. Restless leg syndrome. These are all under the parasomnias. Then moving on to substance medication-induced sleep disorder, other specified insomnia disorder, unspecified insomnia disorder, other specified hypersomnolence disorder, unspecified hypersomnolence disorder, other specified sleep-wake disorder, unspecified sleep-wake disorder. Next main category is sexual dysfunctions. Now require duration of 6 months and on at least 75% of occasion and more exact severity criteria. What was deleted were sexual aversion disorders. We'll just jump right into the subcategories of sexual dysfunction. So remember, the duration is at least 6 months and at least 75% of occasions. Delayed ejaculation, delay in, infrequent, or absent. Erectile disorder, inability to obtain erection during or maintain erection until the completion of sexual activity, or marked decrease in rigidity that interferes with function. Female orgasmic disorder, female sexual interest or arousal disorder, which is a lack of interest or arousal in one interest, thoughts or fantasies, initiation and unreceptive, excitement, pleasure, interest, arousal with external cues, or genital, non-genital sensations. And that was female sexual interest arousal disorder. There's a lack of interest or arousal in these areas that I just listed off. So the lack of interest for at least 6 months, absence or reduced frequency of at least 3 of the criteria. So again, there's interest, 1, 2, thoughts, fantasies, 3, initiation and unreceptive, 4, excitement, pleasure, 5, interest, arousal with external cues, 6, genital, non-genital sensations. Moving on to another category, genitopelvic pain, penetration disorder. These are all new. This combined vaginismus and oh my goodness. I can't say that. Dyspareunia. Oh well. Male hypoactive sexual desire disorder. Absence, which is absence of sexual fantasies or desire. That's male hypoactive sexual desire disorder. Absence of sexual fantasies or desire. Premature early ejaculation, occurs within 1 minute of beginning activity. Substance, medication-induced sexual dysfunction, use, intoxication or withdrawal or exposure, other specified sexual dysfunction, unspecified sexual dysfunction. Gender dysphoria, new, must cause distress and or problems functioning. What was deleted are subtypes of gender identity disorder based on sexual orientation. What was combined was criterion A and B, cross-gender identification and aversion towards one's gender. Gender dysphoria is a new class with revised criteria to better characterize the experiences of children, adolescents, and adults. Gender dysphoria in children includes feelings about oneself and one's gender in reaction to society's expectations of clothing, playmates, toys, activities, etc. Symptoms require a persistent subjective sense of incongruence between sexual anatomy and gender identity. Gender discomfort, insistence on wearing attire associated with the other gender is an example of a symptom of gender dysphoria. Other specified gender dysphoria and unspecified gender dysphoria. Moving on to disruptive, impulsive control and conduct disorder. These disorders are unique in that these problems are manifested in behaviors that violate the rights of others and or bring a client into significant conflict with societal norms or authority figures. The underlying causes of the problems in the self-control or emotions and behaviors can vary greatly across and within these disorders. New specifier is with limited prosocial emotion, showing callous and unemotional traits. People who show this specifier display limited empathy and little concern for the feelings and wishes and well-being of others. These subcategories under disruptive, impulsive control and conduct disorders include oppositional defiant disorder, intermittent explosive disorder, conduct disorder, antisocial personality disorder, pyromania, kleptomania, other specified disruptive impulsive control and conduct disorder, unspecified disruptive impulsive control and conduct disorder. So, oppositional defiant disorder, there are 3 types. And the timetable for this diagnosis is those under 5 years old, the symptoms are most days for at least 6 months. And over 5 years old, the symptoms are at least 1 time a week for at least 6 months. And there is no law breaking. So oppositional defiant disorder for children under 5, the symptom is most days for 6 months. For children over 5, the symptoms are 1 time a week for at least 6 months, and there's no law breaking. So the 3 types are angry, irritable, 2, argumentative, defiant behavior, and 3, vindictive. The criteria changed. So frequency required and severity is required. What was deleted was conduct disorder exclusion. For intermittent explosive disorder is grossly disproportionate behavior or verbal outbursts, temper tantrums. The specifier for intermittent explosive disorder is also prosocial emotion with limited prosocial emotion. And remember, with limited prosocial emotion, showing callous and unemotional traits. People who show this specifier displaying limited empathy and little concern for feelings, wishes, and well-beings of other. Onset at least 6 years old. Symptoms last at least 3 months or 3 violent outbursts with physical damage. So intermittent explosive disorder, grossly disproportionate behavior or verbal outbursts, has the specifier with limited prosocial emotion, onset at least 6 years old, symptoms last at least 3 months, or 3 violent outbursts with physical damage. Conduct disorder is typically diagnosed prior to adulthood, 18 years old. 3 of the 15 possible symptoms are present for more than 12 months, with 1 symptom for more than 6 months. So again, 3 of the 5 possible symptoms present for more than 12 months, with 1 symptom for more than 6 months. I have not listed those 15 possible symptoms here, but you can look them up, and I recommend that you do. Conduct disorder is aggression to people and animals, destruction of property, deceitfulness or theft, and serious violation of rules. And the 15 symptoms go through all the different instances. Symptoms must cause significant impairment in social, academic, or occupational functioning. Clients who meet specifier have a relatively more severe form of the disorder and a different treatment response. And specifier with limited prosocial emotion can also be used with conduct disorder, which means showing callous and unemotional traits. People who show this specifier display limited empathy and little concern for the feelings and wishes and well-being of other. Law breaking is part of conduct disorder. So cruel, destructive, deceitful, aggressive. This is a precursor to antisocial personality disorder. Antisocial personality disorder, there has to be 3 or more: unlawful behavior, deceitfulness, impulsivity, irritability, and aggression. Reckless disregard for safety and self of others, irresponsibility, lack of remorse. Must be at least more than 18 years old to be diagnosed, with the onset before 15 years old. And law breaking is part of antisocial personality disorder, cruel, destructive, deceitful, aggressive. Substance-related and addictive disorders. Deleted was the recurrent legal problems and polysubstance dependence. Rather, each substance is specified. Added criteria is craving or a strong desire or urge to use a substance. What was changed is the threshold of the number of criteria that must be met. Severity from mild to severe is based on the number of criteria endorsed. New specifiers were added for early and sustained remission, along with new specifiers for in a controlled environment and on maintenance therapy. The diagnosis of dependence and abuse are not included in the DSM5, but are used in the field. Dependence equals 3 or more symptoms. Abuse is 1 to 2 symptoms. Rather, symptom of tolerance, withdrawal, and or maladaptive behaviors may qualify a person for this disorder, but there is no hierarchical priority. Substance and severity are specified as mild, 2 to 3 symptoms, moderate, 4 to 5 symptoms, and severe, more than 6 symptoms. Intoxication and withdrawal are defined by substance-specific psychological and physiological manifestations. Substance medication-induced disorders whose symptoms of another mental disorder that occur within 1 month of substance use, intoxication, withdrawal, or exposure to a medication. And I will list the subcategories: substance-related disorders, substance use disorders, substance-induced disorders, substance intoxication and withdrawal, substance medication-induced mental disorders, alcohol-related disorders, alcohol use disorder, alcohol intoxication, alcohol withdrawal, alcohol-induced disorder, unspecified alcohol-related disorder, caffeine-related disorders, which doesn't have a use. Caffeine is the only one that doesn't have a use disorder. Caffeine intoxication, caffeine withdrawal, other caffeine-induced disorder, unspecified caffeine-related disorder. Cannabis-related disorder, cannabis use disorder, cannabis intoxication, cannabis withdrawal, other cannabis-induced disorder, unspecified cannabis-related disorder, hallucinogen-related disorders, phenylcyclidine use disorder, other hallucinogen use disorder, phenylcyclidine intoxication, other hallucinogen intoxication, hallucinogen persisting perception disorder, other phenylcyclidine-induced disorders, other hallucinogen-induced disorder, unspecified phenylcyclidine-related disorder, unspecified hallucinogen-related disorder, inhalant-related disorders, inhalant use disorder, inhalant intoxication, other inhalant-induced disorder, unspecified inhalant-related disorder, opioid-related disorder, opioid use disorder, opioid intoxication, opioid withdrawal, other opioid-induced disorder, unspecified opioid-related disorder, sedative, hypnotic, or anxiolytic-related disorders, sedative, hypnotic, and or anxiolytic use disorder, sedative, hypnotic, or anxiolytic intoxication, other sedative, hypnotic, or anxiolytic-related disorder, unspecified sedative, hypnotic, or anxiolytic-related disorder, stimulant-related disorder, stimulant use disorder, stimulant intoxication, stimulant withdrawal, other stimulant-induced disorder, unspecified stimulant-related disorder, tobacco-related disorder, tobacco use disorder, tobacco withdrawal, other tobacco-induced disorder, unspecified tobacco-related disorder, other or unknown substance-related disorder, other or unknown substance use disorder, other or unknown substance intoxication, other or unknown substance withdrawal, other or unknown substance-induced disorders, unspecified other or unknown substance-related disorder. Non-substance related disorders. Gambling disorder is the only addictive disorder. So gambling disorder is a new disorder and it's the only addictive disorder. And it's a non-substance related disorder. Moving on to the next new main category is neurocognitive disorders. Refer to rule out substance use or medication side effects. Delirium, which can be assessed via the mental status exam. Delirium, disturbance in awareness and reduced ability to direct, focus, sustain, and shift attention. Cognitive difficulties, memory impairment, executive ability, language or disorientation, or perceptual difficulties like visual hallucinations or illusions. It's delirium is temporary, reversible, can be caused by medications, dehydration, etc. Symptoms are noticeable, develop over hours or days, varying during the day. They are disoriented to time and place, loss of recent memory, and disturbances in the sleep wake cycle. Other subcategories include other specified delirium and unspecified delirium, major and mild neurocognitive disorder, previously called dementia or amnestic disorder. And there are new separate criteria for major or minor neurocognitive disorders. So there's major neurocognitive disorder and mild neurocognitive disorder. Major or mild neurocognitive disorder due to Alzheimer's disease, most common have plaques and tangles. Major or mild frontotemporal neurocognitive disorders. Symptoms to look out for are aggression. Major or mild neurocognitive disorder with Lewy bodies. Symptoms can include hallucination. Major or mild vascular neurocognitive disorder, stroke. Major or mild neurocognitive disorder due to traumatic brain injury. Substance medication-induced major or mild neurocognitive disorder. Major or mild neurocognitive disorder due to HIV infection. Major or mild neurocognitive disorder due to prion disease, like Creutzfeldt-Jakob and mad cow. Major or mild neurocognitive disorder due to Huntington's disease. Major or mild neurocognitive disorder due to another medical condition. Major or mild neurocognitive disorder due to multiple etiologies. Unspecified neurocognitive disorder. Moving on to the next main category is personality disorders. Personality disorders are associated with ways of thinking and feeling that significantly and adversely affect how a client functions in many aspects of life. It is an enduring pattern of inner experience and behavior that deviates from the expectations of a client's culture. The pattern is manifested in cognition, affect, interpersonal functioning, and/or impulse control. So the pattern is manifested in cognition, affect, interpersonal functioning, and/or impulse control. Most begin in the teen years when the personality further develops and matures. As a result, almost all people diagnosed with personality disorders are above the age of 18. And this was a previously an access, which no longer exists. So there are three main clusters. There's cluster A, B, and C. Cluster A are the odd and eccentric. Cluster B are the dramatic, emotional, erratic. Cluster C are the anxious and fearful. So I'll list the subcategories and then I'll dive in. So cluster A, the odd and eccentric, include schizoid personality disorder, paranoid personality disorder, and schizotypal personality disorder. Cluster B are the dramatic, emotional, and erratic, include antisocial personality disorder, borderline personality disorder, narcissistic personality disorder, and histrionic personality disorder. Cluster C are the anxious and the fearful, which include avoidant personality disorder, dependent personality disorder, and obsessive compulsive personality disorder. So going back to cluster A, the odd and the eccentric. So the schizoid personality disorder has no interest in relationships. They avoid them. They're apathetic. They don't care, not interested in relationships. They're a loner. They have a flat affect. They're like a robot, an android, introverted, withdrawn, lacks desires to have any relationships, usually works night jobs. That would be the schizoid personality disorder. The paranoid personality disorder avoids social situations for fear people are going to use information or situations against them in some way, and they may have delusions. They're prone to angry or aggressive outbursts. They're untrusting and unforgiving, and they fear being criticized or exploited, even though there's no evidence of the claims they make. So it's probably a delusion that they're having, and that's paranoid personality disorder. Schizotypal personality disorder, they desire social relationships, but they're bizarre and people find them weird. So they're magical thinking, strange people with odd beliefs, eccentric clothes, distorted cognition. I'm having technically. Okay, I got hit a little bit of technical error here. Hopefully I'm still recording. Bizarre magical thinking, strange people with odd beliefs, eccentric clothes, distorted cognitions and perceptions. They want social interactions, but people find them weird. And that's schizotypal personality disorder. Cluster B are they're dramatic, emotional, and erratic. And the antisocial personality disorder, the lawbreaker, they're unable to socialize because they break social norms. They're referred to as a psychopath. They're the grown-up conduct disorder. They're impulsive, irresponsible, callous, belligerent, aggressive, irresponsible, violent, fails to conform. They hurt people for personal gain, and they lack empathy and remorse. That's the antisocial personality disorder. The borderline personality disorder, they have love-hate relationships, instability, suicidality. The cutting engages in unstable relationships and will do anything to initiate and maintain them regardless of the negative consequences. The impulsivity in males differ from females, and there are mood fluctuations. In order to diagnose borderline personality, there must have both impairments in personality and interpersonal functioning. Borderline personality disorder people desire relationships, but they are unstable. They fear abandonment. They may have delusions. They may co-occur with bipolar 1 disorder. And men exhibit different patterns of impulse-related disorders compared to women. Oh, so I had, I had already put that in there. Men exhibited different patterns of impulse-related disorders compared to women. And to go back to cluster A with schizotypal personality disorder, I didn't cover it in the schizophrenia category, which it's over there as well. They're most likely to transition to schizophrenia spectrum. So that was schizotypal. So back to cluster B, dramatic, emotional, erratic. We just covered antisocial personality disorder and borderline personality disorder. Now we're moving on to narcissistic personality disorder. Everything is about them. They demand respect. They're preoccupied with success, money, love, acceptance. They're highly manipulative and hurt people without empathy or remorse. They have an inflated self-image. They're oversensitive to failure, attention seeking, absorbed by fantasies, will do anything for power, control, love, prestige. Entitled, better than others, demands respects. And that's narcissistic personality disorder. Histrionic personality disorder is the attention seeker. They have mood swings. They're seductive. They're the drama queen, the melodramatic, provocative, excessive levels of emotion, uncomfortable when situations are not about them. And that's histrionic personality disorder. Moving on to cluster C, the anxious and fearful. The avoidant personality disorder, they want relationships, but are scared. They avoid social situations and new activities because they fear judgment or rejection. They're extremely shy, people-pleasing, hypersensitive to rejection. They get embarrassed easily, and they feel inadequate, and they avoid situations where they could be criticized. And that's the avoidant personality disorder. So avoidant. They want relationships, but they avoid them because they are afraid of being judged and rejected and criticized. The dependent personality disorder depends on others to survive. They're a martyr and they needs to be needed and requires excessive reassurance and advice. That's the dependent personality disorder. The obsessive compulsive personality disorder is obsessed with being the best. They're rigid, overly controlling, inflexible, highly structured, perfectionist, orderly, conscientious, stubborn, rigid. They hoard money. They're productive, anal, and have high standards. That's the obsessive compulsive personality disorder. Then moving on, there are other personality disorders, personality change due to another medical condition, other specified personality disorders, and unspecified personality disorder. Moving on to a main category of paraphilic disorders, new specifiers in a controlled environment and in remission. Disorder added to names to distinguish between behavior and disorder must have both qualitative criteria and negative consequences to have the disorder be diagnosed. So, subcategory of paraphilic disorders include voyeuristic disorder, the peeping Tom, exhibitionistic disorder, flashing, fracturistic disorder, rubbing pelvic area against non-consenting adult or other, sexual masochism disorder, receives pain, sexual sadism disorder, inflicts pain, pedophilic disorder, involves children, fetishistic disorder, body parts are non-living, transvestic disorder, not related to gender identity, it's cross-dressing, and it's specifically with sexual gratification. Other specified paraphilic disorder, unspecified paraphilic disorder. So remember, must have both qualitative criteria and negative consequences to have the disorder be diagnosed. And the new specifiers are in a controlled environment and in remission. Next category is other mental disorders, and the subcategories include other specified mental disorder due to another medical condition, unspecified mental disorder due to another medical condition, other specified mental disorder, unspecified mental disorder. Okay, on the home stretch. Medication-induced movement disorders and other adverse effects of medication. Tardive dyskinesia. Impaired nervous system due to long-term antipsychotic drug use. Often results in uncontrolled movement of the face, mouth, or jaw. Is a possible side effect of a long-term usage of the older antipsychotic medications called Haldol. Acute dystonia. Abnormal positioning, postures, or muscle spasm caused by antipsychotic, antidepressant, and antiemetic drugs. Akathisia, uncontrolled urges to move, fidget, walk, etc., related to antipsychotic meds. So that's tardive dyskinesia, acute dystonia, abnormal positioning and postures or muscle spasms, akathisia, I know I'm not saying this right. Akathisia, uncontrolled urges to move. Moving on to the next category, other conditions that may be a focus of clinical attention. not mental disorders. Child abuse, neglect, relational problems, educational and occupational problems, housing and economic problems. And conditions for others further study: attenuated psychosis syndrome, depressive episodes with short duration, hypomania, persistent complex bereavement disorder, caffeine use disorder, internet gaming disorder, neurobehavioral disorder associated with prenatal alcohol exposure, suicidal behavior disorder, non-suicidal self-injury. And the other thing that I don't have listed on here, but is very important to look up, I just didn't have time, is be sure that you look at the cultural formulation interviews. There's 16 questions, and I don't have time to go over it. But there are a lot of people doing videos on YouTube about it. The cultural formulation interview, which is in the DSM5, and there are 16 questions, and they're important to know. All right, this concludes. If you find if there are errors or you'd like me to add something, just put it in the comments in case I do another, if I redo this again to make it better. That would be helpful. Thank you. Good luck on your test.